hospitals crazy. So we have helped to create a system, both in terms of public policy and in terms of many of the things that we cherish, that have added to the complexity of this system. And I think the topic we're talking about today is one of the unfortunate unintended consequences. So if we have insurance that comes from employers, why is it that we have such a large number of unemployed? Well, first there's the issue of cost. If the cost, many of you may remember Lee Iacocca's comment, again we're talking about 10, 15 years ago, where he said that the cost of health insurance was greater than the cost of the metal in the cars that he was building. So we're dealing with a significant cost to employers, and as that cost rises, it is a cost of doing business, and for businesses for which insurance is not required, and in New York there are company-size thresholds, in other states there are no thresholds, there may well be a business decision that says we will no longer provide coverage, which then passes the cost back to individuals. And individuals also make a risk-benefit decision. Some people approach this as something they must have, and therefore they will purchase it, and others who are a little bit more risk-tolerant, hopefully younger than I, hopefully healthy, will make a decision that they don't need coverage, but that's a bit of Russian roulette. But these are issues that go into the insurance decision. There's a lack of knowledge. There's a lack of knowledge about some of the things we've been talking about. What are the implications of having no insurance? And there's a lack of effort on the part of some people. It's not, if you are young and you are healthy, it's not something that becomes your top priority. I'll also say that there is a component where charity care actually serves as, if you will, a buffer to the absence of insurance, because people can always come to a hospital in this country with an acute problem and they will be cared for. I think that's an essential buffer. But if you happen to have marginal resources for this expensive thing called health insurance, you know that if things don't go well, you can go someplace and get care. Now, if you happen to be among those with chronic disease, that's a terrible way to get treated, and because, in fact, the outcomes are not nearly as good if your illnesses are not managed. So I think there are many components to the reasons why we're seeing this escalating number of uninsured, and certainly most of those end up being economic factors. How do hospitals respond to this issue? Well, I've already mentioned that we have an obligation to take care of patients regardless of their ability to pay. What I put down here is a statement that comes from the American Hospital Association, just to show you what some of the AHA guidelines or principles are, which I personally embrace, and I'll show you that in a minute, and that is treat all patients equitably with dignity, respect, and compassion, serve the emergency needs of everyone regardless of their ability to pay, assist patients who cannot pay for all or part of the care that they receive, but then the caveat that you do have to balance the needs of the patients who cannot pay with the needs of maintaining a financially viable institution. Many of you are probably aware of the most recent New York State position on hospitals, and that is, as the federal government has its base closing commission, New York State has a commission looking to see which hospitals should close. And it will, in fact, be not just community need, but it will be which hospitals are financially viable. This is an initiative by the governor that will play out over the next year and a half, and there will be recommendations to close hospitals that cannot be sustainable economic entities. So this is not theory. This is playing out in reality, and so these things have to be balanced. What I did is put down some of the language from the downstate financial aid and charity care policy, because this is something that I have to live with on a day-to-day basis. And I think you'll see reflected in this much of the spirit of the American Hospital Association standards, and that is our mission is to render care to all patients in need regardless of ability to pay. We will, in fact, provide charity care. We will provide flexible payment plans to those who are unable to pay for medically necessary services. We will accommodate with various plans up to about 400% of the federal poverty level. The problem with that is when many of you see hospital charges or even Medicaid allowable payments, you will see some rather large numbers. Health care is incredibly expensive, so even when we go up as high as 400% of that federal poverty level, you're seeing people with rather modest means with an obligation to make payment for the services that they require to varying degrees. And, of course, these discounts that we're providing are based on a patient's financial status. Let me ask another set of questions, and that is, how has the American society responded? This is not at all new. This is the data that I'm showing you here come from a Christmas card that the health economist Uwe Reinhardt sent out about a dozen years ago, and it was a card that asked for responses. First question, should we have universal health care in the United States? The answer overwhelmingly is yes. 85% said yes. Okay, we're going to have universal health care. Whose responsibility is it? And the answer to that is it's the federal government's responsibility. All right, how can we finance this? 65%. Let's do it with taxes. Wonderful. Would you as an individual be willing to pay an additional $50 in taxes per year so we can in fact address this issue? And the answer? Not really. Only 25% said yes. So we can't blame this entirely on the folks we elect in New York to Albany or in the federal government. This is a very complex issue because ultimately somebody does have to support the economics of health care, whether it's at the physician level or the hospital level. And here you're picking up a rather interesting tension. I know there's a problem. Of course we have to solve the problem, but not in my backyard. So we're struggling with this very issue. Let me try a slightly different tack and then end. What I've done here is adapt the history of American health care from Paul Starr's book, one that is really quite marvelous for those of you who haven't read it, The Social Transformation of American Medicine. And I've adapted it in terms of a set of ethical principles. And that is, for each of the periods that Starr talks about, what was the major ethical driver? Pre-scientific, this is 18th, 19th, and early 20th century. The principal driver for healthcare was really do no harm. It was non-maleficence. Then we started moving into an era where we were actually able to do things for patients. The professional authority or scientific era, as some of us would like to think of it. Then our ethical challenge was to do good. We were actually trying to do positive things for patients. And then we move into the middle parts of the 20th century, and we start with a growing health insurance industry.